Good evening, everyone. We will not waste much of your time of this weekend, Saturday. So we chose this time 6 to 7. And I hope you will enjoy a little bit of learning about diabetes, because diabetes is a disease which will never go from our lives, and the patients will never go from our clinics. So I think we should try to know as much as possible about diabetes. I would request our President, Vice President, Mr. Dr. Kapil Vora, to just start the webinar. Sir, please.
Good evening, friends. It's a privilege to have Dr. Ramandeep Singh amongst us, and it's my privilege to introduce him to you. An excellent human being and an excellent surgeon also. Dr. Ramandeep Singh is currently working as professor at Advanced Eye Center in PGI Chandigarh. And his main area of interest are diabetes, age-related macular degenerations, retinal surgery, of course, and intraocular infections, especially HIV. He has around 200 publications in various international and national peer-reviewed journals. He has given more than 250 talks in various national and international conferences. He has co-authored a book on diabetic retinopathy. He has won J.M. Pava Award for the best paper at Vitreoretinal Society of India meeting in 2007. He has won the best poster award at an annual meeting of American Academy of Ophthalmology at Chicago in 2014. So married to an equally dynamic surgeon, corneal surgeon Dr. Sujata, and is blessed with two beautiful children, 15 years old son Arush and 12 years old daughter Ipsita. It's an honor to have him amongst us. Welcome, sir. Let's start the proceedings.
Very good evening, everyone. Am I audible? Am I audible, Mohit?
Yes, clearly.
Yes.
Yes, sir, you are audible. You are audible.
Thank you so much. Many thanks to the Ambala Ophthalmology Society for this wonderful invitation, and especially Dr. Vora, Dr. Mathur, and who, despite of their busy schedule and not their other speciality, they are here with us. And it is, again, I'm thankful to Dr. Ruchi and Dr. Mohit for taking this initiative, because whatever, as Dr. Ruchi said, whatever can be taught for the management of diabetic patients is less, because we are going to see a boom in diabetes, and will be a diabetic capital soon because of the various reasons there. So these patients are there, going to stay there. And it is important that we manage these patients, since they get visual loss because of the two reasons, that is proliferative diabetic retinopathy, which causes severe visual loss, and then it causes moderate visual loss, which is caused by DME, diabetic macular edema. And Dr. Mohit will be tackling that part. So both the part will be covered, and I'll be dealing with a few pearls with the diabetic vitreous surgery. What are my experiences, how I'm managing these patients. Sorry. So as we all know that the diabetic vitreous surgery, the indications has very well been described, that we have a vitreous hemorrhage there, and we don't wait nearly, if it's vitreous hemorrhage is there for 4 weeks, and patient has bilateral vitreous hemorrhage and issue with the, is one-eyed. So we tend to operate these patients early, because now the diabetic vitreous surgery is much more safer, because of the small gauge, because of the new instrumentation. So we operate them diabetic vitreous hemorrhage patients early and follow them with the ultrasound. Moment you see something, some retinal detachment or a break happening, we may take them early. The 4 weeks is not the rule here. So you have a tractional retinal detachment, which is, threatening the foveal center, or which is involving the macula. Again, a traction retinal detachment is going to progress because of the ocular movements, and patient will have a macular involvement and he loses vision. So you can't leave a macula detached for more than 3 weeks. The 3 weeks is the window. If the macula is detached for 3 weeks, your visual gain will be suboptimal. So you operate them early. In combined RD, of course, you have a break there. It will become a reg RD, so you operate it as fast as possible. Premacular bleed, because of these the blood, the particles, they are not friendly with the photoreceptors. They cause permanent damage. The moment you see a premacular bleed, you need to take it out, and there are various studies, but as soon as possible, as soon as the patient is fit, please do it. Sometimes you have to clear the vitreous to be able to do a PRP or do manage the diabetic macular edema. So you sometimes remove asteroid hyalosis in these patients, and it is very common in diabetic patients. You must remember that. Despite, there are pearls there. I'm not the first one who's talking about the pearls there. So some pearls I call golden pearls. These are given by big people, Payman, Dr. Payman, Dr. Steve Charles. They always say that identify the correct plane, because there is something called vitreoschisis in diabetic retinopathy. And using various delaminators, scissors, forceps, we delaminate, segment, and eat with the cutter. This is the conventional teaching, and this is how you manage diabetic epiretinal membranes, diabetic TPHMs. And some people say they laser the bleeders because the cautery causes more damage. So there are areas where you can't get away with the cautery. You can do cautery, but the laser the bleeders, it's in attached retina is a possible thing, and you must try, because laser doesn't cause that necrotic retina than what cautery causes. Aim for no break surgery. Causing a break there in a diabetic patient, you are converting into the rec component, PVR, fibrin, and zero tolerance for a break. But they do happen. If they happen, then you have to, where to manage, how to manage it. Add a buckle if there is an inferior break. It will take care of so many things, the fibrin component, and you will be able to support the break if it's a supportable break. No silicone oil. Yes, it's not a rule there, but we always try and put silicone oil in these patients. But remember, silicone oil is causing some kind of a compartment there. It is not letting the oxygen supply properly to the whatever retina is is working. So visual loss is, the visual gain is not as good in which the eye is silicone oil. But in desperate attempt, one-eyed, the retinectomies, and you have to sometimes put oil, but again, oil should be your last priority in these patients. So what happened to these pearls? Because these were given at a time when the 20 gauge vitrectomy were there, the small gauge was not very popular, the anti-VEGFs were not there. So many advances have happened. So these are the advances, that you have cutters which have something like cutting of, we used to, 1998, I used to talk about 800 cuts per minute. Now we talk about something like 10,000 cuts per minute. So it's so safe. You can just go near the retina and you can adjust your vacuums. You can do a 3D vitrectomy. Your vacuum and your cutting, both are under control. And then somebody very smart thought of this, a cutter which is a beveled cutter, which is the contour of a posterior pole. It's a very smart idea, because you have a cutter there which you can see above that. It's very near to the retina, so you can go under the beneath the membrane. So the cutter has become suddenly a multitasker. It has cut the retina, it has segment the retina, it can delaminate, it can do everything. Again, the small gauge, we moved from 1 mm to 0.6, 0.5, 0.3. Though they are more flexible, but they are very, very friendly instruments, and they are, boon to the vitreous surgery. The results have increased a lot. And again, the viewing systems, we have moved from contact lenses to something like 110 degrees, 120 degrees of view, excellent stereopsis. And we have dyes there, the vital dyes, the triamcinolone, to stain the, the residual membranes or remove ILM. And then we have got new instrumentation, like you have OCT, which can be done on the table to see whether you have left a residual membrane in patient of a diabetic vitreous surgery, because it's common to leave membranes if you don't find the right plane. And new tool in the viewing system is, the 3D viewing is also there. So what are my pearls? What do out of doing surgery for last 15 years? So I think the good plan, when you have vitreous hemorrhage, a good plan keeps a good ultrasound done by the retina surgeon himself. It gives them a mental picture that what is he dealing with. And it's a 1 hour surgery, it's a 2 hour surgery. I'm going to need a buckle there. What all I'm going to need. And then draw a drawing, keeping a mental picture that where are we know that the fibrovascular proliferation will be the disc there or in the arcades there. And you can see that whether TRD is literally, it's a flat one or it's a lifting one. A good USG is a must, and a retina specialist, if he doesn't know USG, doesn't do his USG himself, I'll say that, but we should do it actually if you want to learn one thing from my talk. And then anti-VEGF, we all know that. And the few pearls which I've collected, 3 to 5 days is the key. 7 days, I don't think it works. I think crunch phenomena, you must know that tractional RD is a fibrovascular component. You're creating it a fibrous component, and it contracts and it crunches and it increases the RD, and it causes, the combined RD. So whenever the patient is given consent and it is cleared by your GA surgeon or anesthesia guy, only then you plan to inject, and within 3 to 5 days you give it actually. And there is latest that always give a post-operative anti-VEGF, because all your anti-VEGF which was you have given pre-operatively, it has been eaten away. There is nothing left. Post-operative anti-VEGF will take care of your inflammation, your fibrin, your the bleeders there. So many things. It's very important to give it a post-operative cure. Pre-operatively, it is not to be given in each and every case. Once you see the PVD is there, there can be 3-stage situation. The PVD is there, partial PVD is there, no PVD is there. So partial PVD and PVD, no PVD means you give anti-VEGF. If the PVD has already occurred, vitreous hemorrhage, there is no point of giving pre-operative anti-VEGF, and probably you go inside, clean the vitreous, and then you see whether there is need of post-op. You can, this is my pulse on the anti-VEGF there. So now lifting hyaloid from the disc and the peripapillary area. This concept was an old concept, people used to call it en bloc dissection. Now people are no longer using that term, but we do a kind of an en bloc. We do an inside out delamination. I'm very fond of it on the disc and the peripapillary area. Again, the caution, the caveat is it is done on the peripapillary area. Don't try to do anywhere else. So this is, I'll start playing my videos there along with the pulse there. This is a patient, we'll have a vitreous hemorrhage, a bleed, the RBCs, lots of them are lying on the, so cutter is being used. And see, I am still fond of scissors, still fond of all these things. And this is my forceps there. I know that is something peripapillary. I will go and pull up this en bloc. I am doing it very, very slowly. I'm cautious that I might not cause a break there. So if I find any resistance, I'll stop it. So this is how en bloc, or let's not call it en bloc, inside out delamination has been done in this patient, and you can do it in these patients. And most of my patients, you will see I keep do fluid air exchange in these patients. Why? I'll just soon detail you. And then there are pearls, 4 or 5 pearls. I've written it together because I'll be explaining them in the next surgery. Keep doing laser in between. I'm very fond of it. So pre-operatively, if there is an area where the laser can be done, always do it. All right, pre-operatively. Always take the surgery, because more laser has been done, the more things will be all right. Less will be the inflammation in the eye, and less will be. But again, the anti-VEGF is taking care of all of this. If you are not able to do it, fine. But if you are fine doing a vitrectomy, now as soon as you see area which has not been lasered, I am very fond of doing laser, because I know that somehow I'm doing this surgery and I find a bleeder which I'm not able to stop. All the fibrin will collect there. It will be difficult for me to laser it later on, but I am fond of doing laser in between. find the right plane. I was already said, do a delamination or whatever method, we'll talk about it. New vitrectomy probe is a multitasker, but there is always a but. All right. So keep your forceps, keep your scissor, keep your extrusion tips, the silicone ready, because you can use these instruments, and don't rely on the vitrectomy probe always, because sometimes scissors works very well. Sometimes the forceps works very well, as I've shown in the inside out delamination. Keep cauterizing or doing laser in between the bleeders. If you have a bleeder there, don't leave it, let it bleed. No, you keep on doing the cautery and then move ahead. Only place you will not do cautery and let it bleed is on the disc. If something bleeds on the disc, just raise the pressure, bottle height, let the clot form there and tackle it later on. All right. So we're not supposed to laser over it. We're not supposed to cauterize over it. So rest anywhere the bleeding is occurring. First, take care of that. Remove the surrounding blood, cauterize it, or this thing, because you let it bleed, there will be a fibrin accumulation on the disc, and it will be a new ERM membrane. And again, your things will, because anti-VEGF will not help. If there's a major bleed there, because you have done most of the vitrectomy and the things have, that thing is not there right at that time. I'm very fond of 360-degree peripheral dissection with depression. Again, I am taking care of all the vitreous RBC stuck in the vitreous skirt in the periphery. This is taking care of your loose bloods, because your patient will have a loose blood after the surgery. I'm very fond of doing depression inferiorly, because I know that there is a skirt of vitreous there which is full of RBCs there. I do a 360-degree peripheral depression in all these patients. And again, fluid air exchange had its benefits. It takes care of the bleeders there. If you have a bleeder there, unnecessarily because once you remove your cannulas, you're causing some kind of a hypotony there in the eye. Whenever there is a hypotony, these clots break away, these bleeders start bleeding again. And once you're out, you never know what is happening. So air fluid exchange, make sure that, the pressure is okay. And I try to suture these wounds unless until I have a very good reason that's a small surgery, 30 minutes I'm in and out. But if it's a long surgery and I'm reusing the instruments, I will suture it. I will never give it a sutureless surgery, because I believe in small gauge, but not in a sutureless vitrectomy. So this is the next video I'll be playing, because I'll be talking about all these pearls in this. So again, a vitreous hemorrhage there. You can see a peripapillary TRD going on nasally there. And as soon as the hemorrhage is clear, I will be doing a laser here. Can you see? You can see me doing starting to do laser in this patient. Yeah. So this is where I immediately go ahead and I complete the laser photocoagulation in this patient, and wherever the laser has not been done. And once the laser is done, I will then take care of the go ahead and do that the management of that tractional retinal detachment area. So laser can be done again. It's not a rocket science, but again now I've gone on to the TRD. See, I'm looking for a plane between the retina and the hyaloid. So I have started from the anteriorly. I've come from anterior posterior. So you can, to find a plane, you can work posterior to anterior, anterior posterior. So with the little, this thing, I'm nudging out, the hyaloid is separate from the retina. And in this way, I'll be able to separate the traction. So if I work on the now TRD now, it will not cause peripheral traction there. So first, I will remove the peripheral link of the traction with the periphery, because if I work here and there's the peripheral traction, the chances of this thing are more. So now I am using my cutter as a suction tool. Can you see this as a multitasking I'm doing? And with this, I am taking out these membranes. I'm trying to find a true plane there. Once I found a true plane, then I'll take help of the forceps there to lift whether I'm able to do it or not. See, I couldn't do something, pick it up in that area, so I left that area. I went ahead and moved to other area, and see now the scetic membranes, they were not seen there, and practically now they're coming. So now we have found a new plane there to work, and this is how both the forceps and cutter will help us. Now, since we have found a plane there, now I'll go with the bevel cutter there under the membrane. And every time I hinge the membrane and see the retina is not stuck there. So this is all being done under the direct visualization and under high magnification. And so that I don't engage the this thing. And you do a unimanual surgery, you do a bimanual surgery, it all depends on your comfort. Again, now there's a bleeder there. I'm cauterizing that node because I know that if I don't cauterize them, it may cause a problem in these patients. So again, I've said the new multitasker is a new probe is a multitasker, and this is what I'm going to explain in the next video. Now, this is a video of a patient with a tabletop kind of RD, and this is where you see that I'll be using the cutter as for a segmentation and the delamination. I just segmented the membrane and between the nasal and the temporal part, all right, and then I will see this. Once I've segmented, I'll cut the membrane. I'll keep the cutter away from the retina, and then I know that retina and this thing are far away, and because it is done under direct visualization. See, I saw that there is a bridge there, so I go under the membrane and cut it, and this is all being done by a single instrument. Again, to emphasize that you can use whatever you want to use, but it has to be safety is the thing is that you have to cause no break in this patient. So you are delaminating and segmenting only with the cutter. And again, these are edited videos, but as a VR surgeon, you must know that you go there and lift the membrane and see whether there is an attachment with the retina or not. But this can be done with the one instrument there. So I've already explained the keep cauterizing and doing laser in the bleeders. The pearl number 10 is in case of a tractional or a combined RD, choose your technique. Like I've said, people are very fond of bimanual surgeries. They use this chandelier to keep both hands free. And in one hand, the forceps is kept, and other hand, the scissor can be kept, or a cutter can be kept. I mean, this is your own. I mean, if you are okay with the bimanual, unimanual, you can do. But I think if there is a retinal detachment, the bimanual technique works the best. You know, if there is a bullous RD or a combined RD or a reg RD, the bimanual is the safest approach. But in case of a tractional retinal detachment, you can get away with the unimanual this thing. And then again, the pearl number 11 is learn to work with the non-dominant hand, because when you are upper temporal, upper nasal kind of a vitrectomy you're doing, you need to use your other hand to complete the dissection, because it becomes very difficult sometimes to doing with the dominant hand. This I'll be explaining in this video there. Again, a patient with the vitreous hemorrhage and TRD. So once you So again, I found the area which is unlasered. I just stopped my vitrectomy and went for that. Now I'm ready to do my TRD dissection. I took the help of forceps to create inside out en bloc. And moment I found the plane, now I'll go ahead with the cutter there. And again, I will do segmentation and delamination. So anybody could have used a bimanual there. But again, I know that I am able to see the far periphery, the edge of the TRD. So I'm able to do it because I'm using a wide angle system. And if you are not okay with this system, you can use bimanual. It's up to you only. So I'm using a single instrument, but I am seeing a plane there and creating a separation between the retina and this thing, because there already the traction retinal attachment is there. And slowly, I am using 3D. I am using this thing, the minimal this thing. You can see the cut rate is 7190, vacuum is 65, and these all parameters are coming up very well on the monitor actually. So this is what always try and do the inferior part first, because by that time you are you're fresh during the surgery, always do inferiorly, because if you create a break inferiorly, then you have your whole management plan might change. You may have to put oil there. Inferior breaks are notorious. So always dissect inferiorly first when you're fresh. All right. Then go to superior part. Superior, you create a break, you can end up putting a gas there. It's all right. But I always, whenever there's a tractional retinal detachment involving the whole thing, I will go for the inferior part first. I'm sorry, this video is stuck there. So I will, like I said, I'll go for the inferior part first, and then I will go for the superior part. Again, the process is same, the delamination and the segmentation done with the cutter. And again, you have to remove all the traction. I mean, there's no get away with that. You cannot leave the nodes behind. You have to keep keep cauterizing. And if you leave a traction there in the periphery and do extensive PRP around it, I mean, you should not be making it a rule there. I mean, sometimes, occasionally, see now my left hand come. I was not, now I'm operating with my, using cutter with the left hand. So this is where the role of retina surgeon, being ambidextrous, you have to use your other hand to take care of these kind of this thing. And then you can always move to the other one, because you are using these small gauge with valve cannulas, and the system is so safe nowadays so that you have to really struggle hard to create breaks in these patients. But with a high cut rate, you are not able to do this thing. So this is see, I've taken care of all the membrane there. You can see the subretinal blood in this patient, and all you have to do is now do the fluid air exchange and complete your laser there. So again, the next video I'll be showing find the right plane, and the subhyaloid bleed makes the dissection easy. If you have a bleed there under the hyaloid, if you're seeing a red bleed or a yellow bleed, now you always know that there is a buffer between the retina and the hyaloid. So you can safely go and cleave in that plane, because you know that retina is far away from that thing. So you always try to identify that where you want to start there. This will help you find the right plane. So in this video again, you will see apart from the vitreous hemorrhage, you will see the subhyaloid bleed. Now, once you have a hyaloid, which is this is a partial PVD, you know that from here the hyaloid is already detached. So you go and make a hole in it and remove all the subhyaloid blood, and then it's easy to I've told you that PVD already present partial PVD. So this is a case of a partial PVD. You start from the area where the partial PVD is already there. Once you have reached near the macula, then you have to use your cutter or a forceps to create you have to create a space there, or find a right plane here, because already the plane is there, but you have to just go there and lift the retina, hyaloid from the disc. And this is where we have reached now. You can see I'll be using cutter in this patient and trying to lift it with the suction and then cutting. And now you can see this, there is a subhyaloid bleed here, and this will help me in cleaving this area, because I'll be able to, here's a disc is here, so I know that there is a space between these two. I'll just go and cleave this area. So this is again done under the direct visualization of a microscope, and this has been done. Now there is a bleeding from the disc. I'll tackle it later on. I've just increased the bottle height. Now you see that there is a plane, there is an area, the bridge, and the subhyaloid bleed is going to help me there, because I know that there is a blood behind the hyaloid. I'll just go and just remove this traction from this patient, and then I will use the cutter as a suction, and I'll take care of this node first. We have moved back, sorry. Yeah. So now I'm using this suction to take care of this membrane there. And then once the membrane is, lifted from the, stuck there. So yeah. So now with the cutter only, I'm taking care of the pre-retinal bleed. I'm trying to take it out. But again, you can use the extrusion there. It's not necessary to use cutters in these patients. Again, I'm using suction to lift the membrane. I am not lifting it very fast, but I know that there is a subhyaloid bleed. I know that there is a space there. There is no attachment, and then I go on the other side of this thing and cut it and let the membrane come inside from the other side. I'm not directly focusing, looking at the retina there. And this is how now I'm back with my, the extrusion cannula to take care of this blood. And then I want to look for a plane here to take care of this adhesion, because this is the last membrane I have to take care. Now I'm going to try to lift it and block if it's possible. I just left it because I thought there's too much of traction. Then I go and clean more here. So once it's completed, then we do the laser in the area which is there. So now I think the last pearl is you always should invest in the useful instruments and in time, so that they save a lot of complications and take care of the post-operative function and good visual gain in these patients. And first I'll show you this video there. And this is again, there is no PVD there. All right, this is a completely plastered this thing. And you will see me using this forceps to create an en bloc dissection. I've lifted the retina there, and with the endolight, I'm creating a plane there. And this is how I took a risk there to create a plane. But once I've created the plane, now I know that the retina is far off. I'll just create a kind of a divide there, and then I'll take care of this thing. So I'll call myself lucky there, because sometimes experience there. So I could have caused a break there, but again, that is the only way out, because you have to do an inside-out delamination from the disc, and moment you lift it up, and then you find a plane, and then you dissect these patients, and you are able to complete the vitreous surgery in these patients, like I've already shown. And there's another patient, and this patient, after removing the membrane, the hyaloid there, when I saw and looked at the foveal center, that I thought there is another vitreoscetic kind of a membrane there. Then what we have to do is we have to stain with the dye or the Kanakot, and I stained it with the dye and removed the ILM in this patient, just to be sure that I've removed all the hyaloid in these patients. So this is what sometimes you have to do in these patients. And if you don't have a particular instrument, which I'm talking about soon, because role of ILM removal, people have talked about it. Some people have shown disadvantage of doing ILM peeling in every patient. Some people say it's advantageous. So it is still debatable, this thing. So what happens is now I have a similar patient where I'll be using a tool called microscopic integrated OCT, which will show me the exact plane where I'm entering. So you have a taut posterior hyaloid membrane. So this is a MI-OCT running in my the microscope there. Now you can clearly see there is a space between the retina and the membrane there. So you don't have to, you know that there's no risk there. You go and which looks like this area which looks like a pseudo hole. No doubt pre-op OCT in these patients helps a lot. But if you have an intraoperative OCT after the vitreous hemorrhage, you find these situations. Now you know that the retina is far off, and then you are able to take care of this membrane very, very safely without causing any damage to the retina. with the incorporation of MI-OCT, literally for every patient of diabetic retinopathy, diabetic vitreous hemorrhage, we are doing MI-OCT at the end of the surgery also to see that any leftover membranes, so that unnecessarily the ILM peeling has not to be done. So if you find a membrane, we remove it under the the guidance of the MI-OCT, which I'll be showing you. So this in this patient also, once we completed the surgery, I'll be showing you that we did MI-OCT. See, we're running MI-OCT. Now the foveal contour is absolutely normal. This is MI-OCT integrated into the angiounity, and these are not too friendly machine, but we're using it. A friendly machine, I'll be showing that for which this was made. So this is that machine, the original MI-OCT, which came with the Zeiss instrument. So this is how it looks like. I'll be showing the video of this patient. You can see this is a traction retinal detachment. Now every step is there with the MI-OCT. The MI-OCT is also running. This is also running. You can easily make out the black shadow of the cutter there, and see now the plane between the retina and this thing. Now I have to dissect this plane. Now I know that confidently there is a space there. So I will just go and remove it. This is where the MI-OCT will depend intraoperatively. And once you see this now, there's a fine membrane there, which can be seen with the dye or a canapod there easily. But this thing is helping us to make sure that it has been removed completely, and there is nothing like a vitreoschisis kind of layer. See, this is unfurling right in front of you. So this is like a TV in a TV. You're seeing a microscope, and the cataract surgeons are very used to it. The lines there, the cholestos, the toric, the same way we are seeing this. So this is a wonderful tool to invest just to see your diabetic vitreous surgeries and your macular holes and your neurosensory. I mean, everywhere it can be used very, very nicely in this patient. And then I think this is my last video. This is my only indication for diabetic macular edema where I use this MI-OCT. So you have a TPHM there, which is the cause of causing macular edema, which is the cause of where it is not, the anti-VEGFs are not working. I'll do a vitrectomy in these patients. See, now if you have seen clearly that there was a broad adhesion there. So I'm leaving a hyaloid in this area, because if I try to peel this broad adhesion, there will be a macular hole there. So if you will see me that I will not be touching the central area. This is all MI-OCT assisted, and I will be leaving the central area and then taking care of all the traction from the periphery, because I know that if I touch this area, then there can be a hole there, and this will be taken care in the at the last, or I'll be tucking it inside, whichever I want to do. But MI-OCT really helped me to take care of this issue of a broad adhesion, which I could have peeled easily, but it could have caused a full thickness hole there in the side. So to conclude my talk, I mean, you have to read from the books, you have to read the pearls from there, but you can always make your own pearls also, because you always learn from the others' mistakes or own mistakes, and enjoy your surgery, because these are long surgeries. I remember that at one time there used to be 3 hours or 2.5 hours surgery, but with the anti-VEGF and small gauge now they have at least come down to less than 1.5 surgery. So because of the anti-VEGF, because of the instrumentation, so many new things have happened. But always enjoy doing diabetic vitrectomies, because 80% of these diabetic TRDs will gain vision more than 5/200. All right, 80% of them, such good results. And nearly 97% of them, 95% of them will have attached retina. You will lose only 5% of people. All right, 5% of people will go. I'm audible?
Yes,
only
yes.
5% of people will go blind after your surgery. So you have to deal these problems, 5. So you have to, wherever possible, if optic atrophy is not there, if the glaucomatous changes are not there, if the temporal arcade is not completely fibrosed, you should always attempt surgery in these patients, and always audit your cases. This is for own good. And as I've already said, invest in new instruments. As a VR surgeon, we must. Thank you so much, Ambala Ophthalmological Society, for the wonderful initiative, and thank you so much again. Yeah.
Great, sir.
Thank you, sir. It was great. It was really very, very informative and very interesting. I don't know time kaise chala gaya. So it was really too good. So there are a few questions. I think we can take it in the end, as you say.
Whenever you say. Whenever you say.
I think
We'll take it.
we'll have more questions also available to us.
We'll take it in the end. Yeah. Whatever you say.
So I think so now we can move on to our next talk. So I invite Dr. Ruchi. She is a veterinary consultant at LGI Hospital in Ambala for her talk on partnership with patients. Over to you, Dr. Ruchi.
Thank you. Once again, I'll just start my video.
Ruchi, there's an echo in your voice.
Just a second, I'll just share the. I'm having a little issue in sharing my screen.
Your screen is visible, I think so.
My screen is visible?
I think this is your screen is visible. You can just open the presentation, I think so.
No, I just.
Ruchi, there's an echo in your voice. Echo. There's an echo in your voice.
Yeah.
My screen is visible now?
Yes, it's visible. You can start. Yeah.
So, good evening everyone. Sorry, I'm a little new to these things, so it was a little difficult. I had to call my son to start this presentation for me. So, I'll just go through a small story to begin with. This is a story of a 46-year-old male, diabetic since 20 years, and he was having a complaint of blurring of vision in right eye since 1 year. History of on and off treatment with topical steroids. History of cataract surgery in right eye 3 years back, and no other systemic history. On examination, the visual acuity in right eye was 3/60 and left eye 6/9. On slit lamp examination, right eye pseudophakia with vitreous flare and cells, left eye was normal. Fundus examination was hazy in right eye, but it had diabetic retinopathy changes with CME. Left eye had mild LPDR with CSME. So angiography records were available with the patient which showed diffuse leakage in the right eye, suggestive of CME, that is cystoid macular edema, and left eye where there were leaking microaneurysms. this is actually the record of the patient, which I took from the patient. So this is an OCT of the right eye, which shows cystoid macular edema, and this is an OCT of the left eye, which again shows a cystic macular edema. Now, considering 46-year-old male diabetic DV since 1 year, which is cells and flare in left eye with CME. I thought of pseudophakic CME or detritus with CME or diabetic retinopathy with CME, and left eye was clear-cut diabetic retinopathy with CME with macular edema. So considering this, we decided to give intravitreal dex implant in the right eye and intravitreal ranibizumab in the left eye. Post-operative period was uneventful. After 3 months, the BCVA right eye was 680, which is improved from 3/60, and left eye was 6.6. Just if we go through this screen, there is waxing and waning of edema in the right eye. So over a period of 9 months, patient received 2 intravitreal dex implants. And if we see this left eye, the patient received intravitreal ranibizumab 4 injections over a period of 9 months. So with this base, I just want to tell you how much the patient has to reach the doctor, how many injections, and the economic burden on the patient. My topic is not very clinical, but then this is very important aspect which we should discuss. So this is what is patient partnership. This is actually based on patient's experiential knowledge. This is the knowledge which the patient develops from the experience of his psychosocial problems, from the trajectory of care and services, and these problems, how much burden they are putting on his personal life and that of his relatives. So now, from the perspective of patient as a partner, the decision making is between both of the patient and the doctor. It is dependent on the professional scientific knowledge and experiential knowledge, and also on patient's experiential knowledge, and then we have to decide the treatment. So diabetes is a silent disorder which is leading to disabling and fatal complications that are related with increased cost. Now, the long-term complications of diabetes affect almost every system of our body, especially the eyes, kidney, heart, feet, and nerves. Now, among developing economies, the highest increase in people with diabetes will be China, followed by India.
The other questions, I don't know.
So, majority of people with diabetes have at least one, which keeps on increasing. So diabetes care may be very expensive for patients in low to middle income countries, since countries don't offer since in these countries the health is not a subject to government, and the patient has to pay out of his own pocket or the insurance company, whatever, but it is again a burden on the patient. So if we see this graph, we see that average visit by a diabetic patient in 6 months, he at least visits 5 times to a retina specialist, and an endocrinologist around 8 times, nephrologist 6 times, and cardiologist around 2 times. So these are the visits he is making on and off his various doctors. Then patient is affected by other factors like his age. He has to have a company to take him to the doctor, his psychological status, then his expectation for treatment, and then ease of travel. So there are so many factors which actually depend whether is the patient compliant, is the patient coming to you for the treatment or not. So there are other work-related obligations also and other comorbidities also which actually reduce the compliance of the patient, as we can see in this graph. So if we see this 5-year data of PRN treatment, if we see this treatment of anti-VEGFs with DME, these data shows that after an initial first year, the injection actually decreased. But then again, after the 5th year, the injections again began to rise. So the patient can become happy for a few years, but again, the patient has to start going to the doctor more frequently. Now, if we see this real-world studies and we see the anti-VEGF injections, the anti-VEGF injections, if we see over a period of few months, the anti-VEGF injection comes to around 5 to 6. But if we see with DEX implant, the injection over a period of 1 year or so, the injections are very less. So the patient visit is decreased when we use the injections which are little long-lasting. So fewer injections are also less burden to the doctor. That is, frequent injections are also an added burden to ophthalmologists, because if the injections are more, we need to take care of the patient more. There is a risk of infection. Then you have to keep on explaining to the patient every time the patient has a complaint that he is not improving. So there is a lot of counseling. Everything is required if the patient visits you again and again. So treatment of DME or retinal vein occlusion, whatever disease which requires intravitreal injections, or they require multiple hospital visits. And this multiple hospital visits, if we see, these actually the time of the patient in the hospital increases. Like each injection appointment takes around 4.5 hours. These are some studies we suggest, because it also includes the travel time, it also includes your appointment time, and if the patient has to undergo some test, or the patient has, then he has to wait for his turn in OT also. So, and if the patient is working, or the attendant coming with the patient is working, so almost a day off for a patient and his relative. So then this is again a burden to the patient. And then now in this situation, the pandemic which is at present going on, the patient also wants to avoid hospital visits. He wants less and less visits in the hospital, because it is risky for the patient as well, and it is risky for the treating doctor as well to get exposed to more and more patients. So there have been a study by Mr. Siva, by group Siva S. et al. So this study says that apart from the anxiety of whatever pandemic going on, there is anxiety for the patient when he knows that he has to go for a treatment tomorrow to the hospital. So the patient may have sleepless night, patient is not able to relax, and the patient come and tell that he was not able to sleep. And sometimes because of this, the morning when they land up in the hospital for treatment, their sugar level also rises. So more patients with DME, they really complain that their sleeps have been affected, their concentration was diverted. So these all reports actually suggest that a patient coming for a treatment wants to come less and less to the hospital, and that's the need of the hour in this scenario. So in this current pandemic, the most desired improvement to the treatment regime requested by 42% patient was to have less injections to achieve best visual results. And then their requirement of fewer appointments to achieve the same result. They want to come less and less, but they want to have the same result. So factors to reduce the overall practical impact of each appointment, including reducing appointment waiting time and having treatment carried out closer to home, was also requested. So in summary, I just want to say that amidst this pandemic, consideration towards patient and treating social distancing, therapeutic distancing, and quality of life is important. For chronic pathologies such as DME, consideration and planning for the treatment can be better achieved with a longer lasting intravitreals or longer lasting treatment, so that their visits can be reduced to the hospital. Thank you.
Very important issue, and ethical issue which we all face daily. And definitely this is an important factor in determining the actual outcome of the patient. And we really need to think about it and develop the strategies accordingly, by discussing with the patient. Very rightly, you have highlighted this topic, I think so. Yeah.
So now for the last talk, I would invite Dr. Mohit Bansal. He is a practicing vitreoretinal consultant in the Bansal Eye Hospital, and I think everyone knows him very well. So Mohit, please go ahead.
Thank you, Dr. Yeah.
It's 7 o'clock.
Hello, everybody. Am I audible?
Yes, Mohit, you're audible.
Well, good evening, everybody. And after listening such a wonderful talk from Dr. Raman and Dr. Ricci, I will now like to share my views on the medical management of DME. As we all know that the incidence of diabetic retinopathy is increasing, and so are the patients of DME. And with increased duration, the number of patients of DME also increase. And if we go to the pathogenesis, DME is an inflammatory process, and there's a major role of VEGF and also the role of other inflammatory mediators like interleukins, TNF-alpha. And the pharmacological therapy is mainly aimed at blocking VEGF or inflammatory mediators. Now for diagnosis and management, the good slit lamp examination along with OCT is good enough. However, OCT definitely provides us with more information. Apart from just diagnosis, OCT can help us in quantifying the disease, then also helps in serially monitoring the activity of the DME. Also, we can prognosticate the case by seeing various qualitative parameters like the presence or absence of ISOS junction or ELM, or the outer retinal layer thickness, or presence of drill. Also, we can differentiate whether patient has a tractional component like any vitreomacular traction or ERM, or also even presence of any acute or chronic process. Like if there are presence of large cystoid spaces, it points us to a chronic form of DME. So basically, OCT in itself is a big topic and plays a key role in the management and outcome of a diabetic macular edema patient. Now, once a patient, what are the options do we have in DME? We have anti-VEGF agents, steroids, laser, surgery. Now, once a patient walks into a clinic, we have to see various factors so that we can decide the appropriate treatment for the patient. We have to look at the local ocular factors like what is baseline vision, the severity of diabetic retinopathy, any presence of glaucoma, whether it is controlled, uncontrolled, patient is phakic or pseudophakic, any prior vitreous surgery, or systemic status, the systemic control of sugar, BP, lipids, or any recent history of MI or stroke. And socioeconomic factors, as Dr. Ruchi highlighted, is one of the most important factors. Duration of DME is another important factor, whether it is acute or chronic. And if we find out any variable treatment response to prior anti-VEGF or steroids. So all these factors we can have an idea when we have a good clinical examination and a thorough history. Now, before discussing the management, it's very important that we must control all these systemic factors, and because each of these have a independent role in management of DME, and various studies have already proven their role. Now, how do we classify DME? DME is said to be present when we find any retinal thickening or hard exudates in the posterior pole, and then we have to see whether it is central involving or non-central involving. The ETDRS classification is now no longer used. Now, let's look at the various clinical situations. Coming on to the first situation, now when we have a non-central involving patient of macular edema, obviously patient has good visual acuity 6.6. As we can see in this patient, there are presence of hard exudates and the thickening just superior temporal to fovea, and OCT does not show any thickness in the center, and FFA shows the leaking microaneurysms. So the treatment of choice here is a focal laser to the microaneurysms. Now the other situation is when we have a patient of central involving macular edema with good vision. Now this patient just came to me 3 days back, and he has this presence of hard exudates and thickening in the center of the macula, and there is increased foveal thickness also. Now what are the options do we have? First is we can just give him anti-VEGF agent or focal laser to the microaneurysms, or why not observation, because patient has a very good vision. Now this scenario has been studied, and all these 3 strategies have been compared in DRCR protocol V, and what they have found was that all these 3 interventions were comparable, and there was no significant difference in visual acuity loss at the end of 2 years. But we must remember that if they found any time drop in vision of 1 line, the anti-VEGF agent was given, which was in 1/4 patients in laser arm and 1/3 in observation arm. So we must keep the patients under close follow-up if we choose observation or laser. And in this patient, I offered him anti-VEGF injection, but patient refused. So now he's in under observation. Now, the most common situation which we encounter is when patient has central involving DME with moderate vision loss. As in this patient had moderate NPDR with DME with vision of 636. And on OCT, we can see presence of cystoid spaces and spongy thickening along with subfoveal detachment in the center. So the options which you have to choose is whether we should give anti-VEGFs or steroids. Now, there have been various trials like Rise and Ride trial, Resolve, Restore, DRCR. All these have proven that the first choice of agents are anti-VEGF because of their better efficacy and safety. And monotherapy gives the best results. Also, they have recommended first 3 monthly consecutive injections. And they have also observed that there is progressive improvement in diabetic retinopathy severity or slowing progression of diabetic retinopathy with anti-VEGFs. So then next question is, which of these 3 agents should we choose? This was studied in the DRCR protocol T, and what they found was that those patients who had good initial vision, all 3 agents did comparatively equally well. But in those patients who had worse initial vision, After at the end of 2 years, aflibercept was comparable to ranibizumab, but was better than bevacizumab. However, in practical scenario, aflibercept is a very expensive drug, and so we rarely use it. Ranibizumab is the one which we prefer, and in fact now we have a biosimilar for that, so that is a good option. And bevacizumab, because it being least expensive, is now the most commonly used drug, but we have to be very careful because there is risk of endophthalmitis with this. So there are some situations in which anti-VEGFs are to be avoided. Like if they have any history of recent MI or stroke, especially in last 3 months, or if you find any evidence of traction on retina. Now, and this is a case, as we can see, there is a large fibrovascular proliferation over the disc. This patient presented to me with the presence of vitreous hemorrhage, and he received an anti-VEGF injection outside. So in such patients, we have to be very careful because anti-VEGF may precipitate vitreous hemorrhage or traction detachment in these patients. And also in vitrectomized eyes, because in vitrectomized eyes, the anti-VEGFs don't stay for more than 2 weeks. In such situations, the steroid implants are a better choice. Now, which regime to follow? Monthly regime is practically impossible, even in countries like USA. So the other regimes which we have is PRN and treat and extend. What is PRN regime? PRN means as and when required. In this regime, we initially start with 3 monthly doses of anti-VEGF agents. And once we achieve a stable visual acuity, then patient is kept under monthly follow-up. Retreatment is initiated only once there is a drop in vision. And then again, treatment is given till we have a stable visual acuity. So in this, basically the visits are every month, but the injection is only given once there is a drop in vision. In contrast, if we see treat and extend regime, as the name implies, we have to treat at every visit. In this also, we first give 3 monthly doses of anti-VEGFs. And once the patient has a stable visual acuity and DME, then we can increase the interval by 2 weeks and call him again. Even if at that point, patient does not have any worsening of edema and visual acuity is stable, we can further increase the interval by 2 weeks. And this can be done up to a maximum of 12 weeks. However, if at any point of time, there is a drop in vision or worsening of edema, we have to decrease the interval by 2 weeks. So basically the treat and extend regime decreases the follow-up. We have the least follow-up with this regime, whereas the least number of injections are with the PRN regime. So you can very well choose your patients to suit to which regime. But I think so in our clinical scenario, even sticking to either of this is also very difficult. So what I would prefer is that first we can give 3 monthly doses of anti-VEGF and see if the patient has achieved a good vision. We can then call him after 1 month. And then if the patient does not have any edema and vision is okay, then we do not need to give an injection and we can just double the interval. And the injection has to be initiated once we find a drop in vision. So in this, we can basically take the advantages of both of the 2 regimes. Now, now what are the situations which we can have with these injections? The first situation is that when after 3-4 injection, patient achieves a sustained visual acuity, which remains sustained over further time. Then there is another situation where initially there is an increase in vision, but then patient suffers a loss in vision. We again retreat him, and then after that he again maintains his vision. There is also another situation where there is a progressive steady increase of visual acuity gain over a slow period of time, but after that the visual acuity remains sustained. So there is another situation where, now this is a patient who was a 52-year-old male. He has a moderate NPDR with central involving DME. He had a vision of 636 and he has a presence of these cystoid spaces and spongy thickening. In this patient, we gave him 3 injections of Avastin. And after that also there was presence of this residual cystoid spaces and edema, and the visual acuity gain was also very modest. So this is a case of insufficient response. And there can be patients also who are non-responders, means they have continued worsening of visual acuity or there is no decline in thickening. Such patients constitute about 30 to 40% of patients in trials. And in our practice, even these are more. So it is very important that we identify these patients early, because if we identify these patients early, then we should preferably switch them to any other better, more effective agent, either of the same class or steroids. Because if you don't do it early, then we miss an opportunity to resolve edema earlier, which may affect the visual outcome. This has been highlighted in the early analysis of DRCR protocol I, which they found that those patients who had a poor visual acuity after 12 weeks also had poor visual acuity after 1 year. Now, another situation is that this is a patient. He is a gentleman from Solon and he has been under my follow-up since last 5 years. He's a case of both eyes stable PDR with centrally involving DME. And FFA shows this diffuse leakage at macula. He had received few injections of Avastin outside. When I came to me, he had a visual acuity of 636 both eyes and a massive macular edema, spongy thickening. I gave him 2 doses of Avastin and grid laser, but there was no improvement. Then I gave him Ozurdex implant, and 2 months post Ozurdex, patient has complete drying of macula with very good visual acuity. So, what are the situations in which we can prefer steroids, preferably as first line? These are patients of chronic DME or of diffuse macular edema, like this patient, or vitrectomized eyes. In these implants will last for a longer duration, or any contraindications to VEGF. Pseudofix are a very good option, and any patients who have compliance issue, like we see commonly, in which patients cannot come frequently. The options in steroids we have, the first is a triamcinolone acetonide. This is the cheapest of all, and it is a very good option for poor patient and especially pseudophakic patients. The other is a Ozurdex implant. It is a biodegradable implant, dexamethasone. Drug is released slowly over 3 to 6 months. And the third one is a Iluvien implant. It is a non-erodible implant, fluocinolone implant. Though this drug is not available right now, but it appears to be very promising because the effect of this drug lasts for 3 years. And I have many patients who are repeatedly receiving Oracort injections, and these are the patients who will really benefit from this injection. If you look at the safety of steroids among these 3 groups, cataract surgery was definitely high in all 3 of them, and mostly 70 to 80% required cataract surgery. IOP rise was seen in around 30 to 40% of patients, but most of them are very well managed, and very few patients required glaucoma surgery. And out of these 3, Ozurdex was the most safest. So I think in our settings, steroids have got lots of pros, like we require less number of injections, lesser follow-up, they are more economical, and good option in pseudophakic and vitrectomized eyes. Though it has its cons like lesser efficacy, cataract or glaucoma, but most of these are very well manageable. So if at all steroids have to be avoided, I would say these are the patients, either young phakics or those who have advanced or uncontrolled glaucomas. So injections, they do their job. They bring about a decrease in macular thickness, but the problem is recurrence of edema. That is the biggest challenge, because recurrence of edema leads to increased number of injections. So the question is how to decrease this burden of injections. That is the biggest challenge. One of the options is that which I have already mentioned, that we can use the treat and extend regime or PRN regime, but even that is difficult. The other options which we have is the use of combination therapy. In combination therapy, we can add lasers. Lasers have been employed in various trials also as a rescue laser after at least 24 weeks. And I think so in our setting, it has got a greater role because our patients are difficult for follow-up. They have cost issues also. And any patients who have contraindication or side effect with the injections. So in all these situations, I would say we must employ laser also along with the injections. And the other option is the combination of steroids with anti-VEGFs. In that we can use either Oracort or Dexa implant. Although recently DRCR protocol U, it has shown its results, but it has shown that they have seen that those patients in which they added Dexa implant along with anti-VEGFs, they did not find any improved visual outcomes, but definitely more number of patients had macular drying effect. Though the reason of non-visual improved visual outcome could be because they started Dexa after 6 months of anti-VEGF injections, and only those patients were taken who had still not resolved edema. And it is very important to remember that if we have to add steroids, it's better to do it early rather than first waiting for 6 months for non-improvement, because at that point of time we might lose that important time and it may affect the ultimate visual outcome. So I think adding steroids may improve the efficacy also, and more importantly, it will help in increasing the duration, and we probably might require lesser number of visits and lesser number of injections. So if I would summarize, I would say that we must choose the right therapy for the right patient. And for that, we need to tailor our needs according to the patient's various factors, like seeing whether patient is phakic or pseudophakic, what is the status of glaucoma, whether patient is vitrectomized, and is any history of recent MI, and obviously the cost and compliance issues are the very important. And we must remember that switching to alternative therapy early in patients of suboptimal responders. And steroids, though they have higher risk of cataract and glaucoma, but most are very well managed. And in our settings, it is a very, very good option. Thank you everybody for your patient listening.
So we are done with the talks. Sir, I would like to ask one question to you, sir. Sir, if the patient is having thought PHF on OCT, am I audible, sir?
Yeah, very clear. Thank you.
So, should we give a trial of anti-VEGF or steroid, or we should plan surgery for such patients? Sometimes there is edema, but the PHF is there. I mean, attached thought PHF.
What happens is once you vitrectomize these eyes, if you plan anti-VEGFs after that, the anti-VEGFs, the response is not very good. So my answer would be, if you have a focal TPHM, a kind of a where there is a focal adhesion, which you think that giving one anti-VEGF injection will cause enough disturbance in the eye, in the vitreous cavity, that adhesion breaks. So you might try one anti-VEGF injections, but if there is a diffuse TPHM, all right, I think one should not waste anti-VEGF on that. You should go ahead and do the vitrectomy surgery in that patient. But again, the issue is the TPHM is not the only thing which is causing the DME. If there is a pharmacological reason, then you may have to inject these patients with anti-VEGF or the steroids, as Mohit said. But vitrectomy is a good option for a broad-based TPHM.
I have a question, Dr. Amandeep.
Yes, sir.
Addressed to all three of you, starting with you. As a cataract surgeon, from a cataract surgeon's point of view, so a bad case of diabetes with cataract and with obviously some changes in the retina. I heard that some kind of study was conducted in PGI of giving the Azudex injection along with at the time of the cataract surgery in such cases. So would you shed some light on this? What is the advantage of injecting Azudex in such cases?
So, sir, what happens is cataract surgery per se causes some inflammation, all right? That is known. So if it's a complicated cataract surgery, it was called more complication. If it's a good IOL in the bag and good surgery, it will cause less complications. The complication mainly is the diabetic macular edema and the progression of PDR. So progression of PDR is also there, but to a lesser extent. But the progression of DME is very, very disturbing for these patients, because a diabetic patient, if the CSME is there, their CSME will eventually worsen and they'll never be happy patients. So this is something like Irvine gas syndrome, and they will have CSME worsening plus the cystoid macular edema also. To address this thing, the worsening after cataract surgery, then people thought of giving some kind of a prophylactic agent. And this is where we started using this, the dexamethasone implant. All right, that if you give a dexamethasone implant today, maybe on the day of even cataract surgery, we did that also, but people do it 1 week before, or on the day or 1 week later. So Irvine gas syndrome is going to come somewhere 3 to 4 weeks. So by that time, the effect of steroids come, and then it takes care of that worsening of CSME, and patient is a happy patient, I'll say. So this work was Dr. Anirudh's thesis. It was published also, and it was, taken, initially the people said, why are you giving intraoperatively? But yes, you can also give a week prior if you don't want to give intraoperatively, or if you can give a week later. So it works very well for the diabetic macular edema, but not for the proliferative diabetic retinopathy. For the proliferative diabetic retinopathy, you have to give, if there is no traction retinal detachment, you can, there's a flat NV, you can give anti-VEGF injection rather than the dexamethasone implant. But
Dr.
again,
Ruchi, are you there?
Yeah.
Mohit, what is your take on this? Unmute yourself, Mohit, please.
Yeah. Hello.
Mohit,
Okay.
Yes. Sir, as Dr. Raman has said, definitely Ozurdex has got its role mainly in control of macular edema. And these patients, they are definitely more prone for Irvine gas syndrome. And Ozurdex has because we know that the inflammatory component is taken more care by the steroid part, and because Ozurdex is basically a steroid implant, so it will take care of that Irvine gas syndrome. And we will also, because we see that the Irvine gas may develop usually 2 weeks or maybe 3 to 4 weeks after cataract surgery. So we need an agent which should, if the effect should last for a little longer time. And we also want to be safe on that side. So that is why I think so Ozurdex is a good choice for those patients who think that they are more prone for developing DME, especially if we have seen the other eye. I had a patient who had in the other eye underwent cataract surgery and had developed macular edema. So when I was planning other eye surgery, so I was very particular about that we want to avoid this in this eye also, because in that eye also there were changes of moderate NPDR and mild macular edema was there. So if patient is not very well controlled and patient has history of macular edema, these are the patients, they might end up getting worse after cataract surgery. So we have to choose our patients, and Ozurdex is one of the better options, I would say.
Dr. Ruchi, are you there? I think Ruchi is somehow disconnected.
Yeah.
Sir, just reframing this thing for the benefit of those who are not dealing with retina. Normally, post-operatively in cataract cases, we give steroids for a month or so, and then we switch over to the anti-inflammatory, non-steroidal anti-inflammatory agents. This is the protocol in our hospital. So do you recommend that in the cases of diabetes, the steroids are to be continued for a longer period of time? Especially those with the changes.
So I don't think that topical the steroids are going to take care of what is happening in the posterior pole. All right. So if you have no macular edema, then I mean you can do this thing, treat them as a regular patient. But if the diabetic macular edema is there, what is going to work is the steroids inside the vitreous cavity. But I don't think there is any role of steroids there and the anti-inflammatory also. Anti-inflammatory at best reduce the edema by 15 micron or 20 micron. But again, 15-20 micron difference, it happens if you do OCT morning, evening, But I am not a great fan of steroids and anti-inflammatory to take care of the diabetic macular edema part. I want some agent which is a better agent and stays there for a long time. Because once these patients worsens, it's very difficult to control them.
I think Ruchi has reconnected. Ruchi, again, we gave Ozurdex in a few cases during surgery, and now they are under your care. So, because I have not been following them up. So, what was the result? Can you shed any light on that? Your mic is not working.
Sorry. They really do well if we give actually injection along with the surgery. The time, I mean, both the things are done at the same time, and then I have been following those patients. They really do well this way. We have done quite a few patients. I think around 10 patients we have done.
Yeah.
In which we have given injection along with the phaco. Sir, do you recommend starting some anti-inflammatory prior to the cataract surgery? Like some people put the patients on Nevenec or something like that prior to the surgery?
I just answered that question. I'm not
okay,
very
okay, sorry.
Just answered that question.
That actually.
You were disconnected actually.
Yeah, suddenly my internet went off.
Just for the reason for the cataract surgery, not for the posterior segment in the diabetic retinopathy, it will not take care of anything like that. I mean, I am not a great fan of that. Because they say it decreases the edema by 15-20 microns, but that is the usual variation between the machines also. But I don't think it works. If the diabetic macular edema is there and you know it is going to worsen, then you need a better plan. And the better plan is that you give injections, either the implants or the triamcinolone, whichever is there. Even anti-VEGFs, but again, it has to be given every 4 weeks.
Everything.
Dr. Aman, I have a few questions regarding your talk. First of all, I must say that it was a very good talk, and so many things we learned from your talk, and very elaborative talk. So there are a few questions. Like the first is that recently I just did a case. She was a very well, otherwise a stable PDR case, well lasered, but definitely had a bleeding. And she came to me, and there was no presence of PVD, before surgery, and there was a good vitreous hemorrhage, and there was no view SH of retina, but there was no PVD. I injected him anti-VEGF, and when I proceeded with surgery, there was no PVD. And okay, once I started doing PVD, the problem started happening when when I reached till mid periphery. The highlight was very much attached to the all NVs and multiple places, and as soon as I was lifting it, it was so tightly attached, then that led to little start having breaks. So the question is that, first of all, how far should we go? Because otherwise VH I had taken care of early only, because VH was not a big part of it. I had taken care of VH. The only point was that I wanted to separate the highlight till as far as possible, so that patient does not have a rebleeding. But the problem was from how far should I go, and then it was causing more of breaks, because the retina, because of the laser thing, it was already ischemic and very fragile.
So it's a very valid question, and it happens with a lot of people, because once you have did a laser there, there is a scar there. Always remember the highlight will be firmly attached there. We have been taught that if you have a highlight is firmly attached to the disc and to vessels and to scars, so it will be attached there. So what are this thing is, we should try to be as safe as possible, try to remove the hyaloid very slowly. But in case you start seeing these breaks, then you have to take a call that you don't remove it, but you should always try. But you should try enough that you should not cause a break there in these patients. And if you have a retina very well lasered anterior to that area and the posterior to that area, then you can very well leave this hyaloid there also attached, and always try for do no harm, all right, in these patients. Yeah,
right.
Again, it will be a sieve-like retina if you try to pull it up, and it's very difficult.
It is very difficult to even separate, because even a slight pull was causing small breaks.
You should not try to go overboard towards the periphery, but if it is possible, you should try and remove it whatever possible.
It was not even peripheral, so it was little even just posterior. So that was my dilemma. Yeah,
it's mostly mid peripheral.
Yeah, so I could have left it there only. Obviously, I did it later on, but I was just
proper shaving of the vitreous. Proper shaving of the vitreous, remove every bit of that. Proper shaving, and the depression has to be done. You can't leave the vitreous there actually, but don't detach it, just shave it.
Sir, here only one very interesting point you made, that you do 360-degree base dissection even to remove that peripheral skirt. Yeah. Even initially when I was doing residency, I was taught that you usually leave a little skirt there, but definitely that was the cause of recurrent VH. Now, when we do this trimming of peripheral vitreous, we are really worried that we might cause little breaks, because sometimes it is very difficult to identify also because of that blood there, heme there. We are trimming it, but at the end there may be some little breaks there. So it may be a double-edged sword also sometimes. What is your opinion regarding that?
Mohit, where you are talking about is a gray vitreous hemorrhage. If you have gray vitreous hemorrhage, then you are not able to see the periphery and not able to.
I'm talking about that, sir. Gray vitreous hemorrhage, dense gray vitreous.
Nowadays, we don't wait for the gray vitreous hemorrhage. We do a surgery early. We are doing surgery early because we are more confident. The results are better. The instrumentation is better. But of course, you're right. In case of a gray vitreous hemorrhage, if you have if the assistant is not good, then you end up having these breaks. But again, the experience does matter. But in my opinion, more you cut is better. All right. But again, break is not done in these patients. But so you have to take extra precaution in the patients, especially with the gray vitreous skirt. But with the red one, there is no issue. You are able to see the retina behind it. So gray vitreous hemorrhage, use your wide angle systems, use a good assistant, and try to remove as far as possible, as safely as possible. Yeah.
Sir, it's one more question. Yeah. Recently there were two cases of mine Those were the cases in which they have never ever received laser anytime before. And they presented to me with vitreous hemorrhage, dense vitreous hemorrhage, and there was presence of traction. So intraoperatively, I removed everything, and there was obviously a lot of fibrovascular proliferation all around. And there were even the proliferation was also very vascular despite anti-VEGF injection. And I operated on the third day. Now, after this, though, I did a very good job in the surgery, and at the end of it, there was not much of bleeding. In one of the patient, I left it with just fluid air exchange. On this patient, after just as soon as the fluid went away, again presented with this blood. As usually, we usually wait for a few days to settle it down. But in this patient, there was still a lot of blood, and when I did a B scan, I could see some, hyperechoic echoes on the macular area. So I thought maybe some clot has happened. So I again intervened, and I found a very large clot just on the arcade itself. And in the other case also, basically there was a recurrence of bleeding. Although the surgery was perfect. So my question was again, what to do in such cases? Should we either leave, just air or some gas maybe, or how to prevent this rebleeding in such a patient where never received any lasers and extensive proliferation, and there was a lot of bleeding inside the surgery.
So the rebleeds are rarely have been an issue there. Actually, you're absolutely right. In these patients. So this is where the role of the anti-VEGFs
Intraoperative.
at the end of the surgery,
Right.
it comes, and of course, the intraoperative gas exchange you did, that was very important. All right. So, and in the end, when do they bleed? When we are removing the trocars, when you're causing a hypotony there. So you have cauterized the bleeder there, they're doing fine. Moment you remove it, you cause a little hypotony there. So in the air also, the chances of hypotony are always there. All right. So this, to never let the hypotony happen, always suture these eyes. So you can always try, but in a phakic eye, there is always a anterior vitreous cortex which is left behind, and there is an anterior vitreous fibrovascular proliferation happening. So that will happen. But how you can prevent it? To my way is air fluid exchange or SF6 short-acting gases. Don't let the hypotony happen, and inject post-operatively. That is a must, because I think that
At the end of the surgery, half dose, or under air only you inject, right?
Obviously, under air you can give full dose. Under gas, you can try your half dose actually.
So do you leave most of your patients under fax at the end of surgery, and full fax or partial fax?
See, if you my patients are, if I've done enough surgery there are bleeders there, they've cauterized there, I do full FAX in these patients.
Yeah.
But if there is a break also there, then I'll do the gas exchange also in some place actually.
And sir, if you have to choose between oil and gas, in which cases would you prefer oil? Once you told that inferior breaks, any other indication like one eye or something?
I told you inferior unsupportable break. If you have an inferior break which can be supported with the buccal, I'll put gas.
Okay.
So if you have an inferior break which is unsupportable, then the monoocular patient and understands the prognosis, you can put oil, or you've done a retinectomy in these patients, just because you are not able to remove the fibrovascular. So you can put, but again, these oil eyes, they don't do well, because oil you put desperately in one-eyed patients, and then these are my only indications. But I'll not put an oil in a patient so that so that people put oil just so that patient can see next day.
Yeah.
This is what is there. People put oil so that patient can see it, because next day the gas is there, patient is hand motion. Yes. Patient says, what is this going on? You've charged me so much. What is this?
Yes.
I think for that reason, oil should not be put. That very simple.
So there's one question from the audience. Dr. Ashish has asked you, sir, how commonly do we give intravitreal Orocort injections in PGI? And especially if combined with cataract surgery, long-standing diabetes, any risk of endophthalmitis with that? There are two parts. One is whether how often do you give intravitreal Orocort injection in PGI, and do you combine it with cataract surgery? And does it has an increased risk of endophthalmitis if you do that?
So every intravitreal procedure has a risk, its own risk of endophthalmitis. You must remember that. So if you're combining two surgeries, again the risk increases. All right. So the risk of endophthalmitis is always there. You remember that that thing is always there. So are we combining Orocort and cataract surgery? So this is what I have to say is we have not given Oracort intraoperatively same days, but yes, with those patients who cannot afford, we have given them a week prior or a week later for cataract surgery in these patients. But endophthalmitis risk is usual for 1 surgery and 2 surgery. But again, if you use a device or you use it properly, the risk is very low actually. Yeah.
Yes.
My main thing is the rather, you know, high IOP is my main concern, you know, in these.
Sir, so that means you use less often, right? I remember that we used to use very rarely Oracort. But how do you use it? Do you still use it, or sir, it's still not being used right now?
We are using it, Mohit, for some patients, those who can't afford the Ozurdex. We are using it for macular edema.
Sir, here though we are using it in good number of patients, but actually even when I was in Chitrakoot, you know, there, you know, used to give a lot of patients injections, but in half dose, there are few patients who have this high IOP, but I saw, and very, very few, I really remember if a patient had an endophthalmitis with Oracort.
You can safely give 4 mg. That's a safe dose actually. Yeah.
Dr. Ji, any questions? I have
one last question I want to ask. The patient operated for vitreous hemorrhage and then he develops recurrent hemorrhage. So how long do we wait to intervene, or do we give intravitreal anti-VEGF? Yeah, what is your, I mean, what's your opinion about that?
So see, there are 2 scenarios. It's happening in a phakic eye or it is happening in a pseudophakic eye. All right. So a phakic eye, always anterior vitreous cortex is always there. All right. So if it stains the posterior capsule, it is not going to go. Okay. All right. So if it is not staining the posterior capsule of the lens, I'll give intravitreal anti-VEGFs and wait for 4 to 6 weeks max. All right. But if it is staining the capsule there, then I will plan a cataract surgery with the fluid air exchange and the clearing of the capsule, posterior capsule. All right, this will be my approach. So max 4 weeks, anti-VEGF propped up, you know that, and follow up with the ultrasound.
Sometimes, you know, in this situation, sir, like I had a patient who developed a large clot, and it was very, very difficult for me to remove that clot with a cutter also. I went to the lowest settings of cutter and the highest vacuum possible. Still, I was not able to cut that clot, you know. I was really in a dilemma. How should I remove that clot, sir? What is your take? How do we
see in diabetic, you know, clots forming during the surgery or after the surgery, they're very, very difficult. You know, there is no other way. You have to deal with them. You have to cut them slowly. You can't just pull them. Well, if you pull them, they'll cause break there. So you have no choice. People have talked about giving these the anti-fibrinolytic agents, but I don't think they work very well. You just have to be patient, give pre-op anti-VEGF in these patients, go in and try to do again dissection with a membrane scraper, because this clot will have a paw there. It will be adherent to the retina, surrounding retina.
Yeah, so it was
with the diamond dusted scraper, then you have to take out those claws and take it out. That will be very, very meticulous, because it's a very, very risky situation.
Sir, please give your tips regarding, sir, the bimanual. When I use bimanual, I have a problem in chandelier illumination. I don't know, some people have very good illumination. I use it at 6 o'clock, and recently when I was using it, the illumination is not that good. In which, do you have any tips regarding that? Whether to use 2 chandeliers or some other, I don't know. In chandelier, the problem I face of illumination rather than being the bimanual itself.
The chandelier, I think, if you ask the other Mohit Dogra, he is fond of chandelier buckling, So he always keeps the chandelier opposite side of break. All right. So if you have a inferior TRD to to take care, I'll put a chandelier up.
Right.
This is what I learned from him. So it is the opposite quadrant. So if you blindly put it at the 6 o'clock and try to deal every traction, it will not be done. So you go inside first, you do your vitrectomy, and now you see now which quadrant chandelier. So you could literally put 2 chandeliers, you could put, chandelier anywhere except for 3 and 9. So 6 o'clock is not the solution for everything.
No, yes, no, absolutely.
Opposite side pe.
Yeah.
Best illumination opposite side pe hoti hai.
I think we can, sir,
yeah.
what Doctor, I would request Dr. Kapil Vora, sir, to wind up if any questions left.
I think it was a wonderful session. It was scheduled for 1 hour and almost near to more than 1.5 hours. It was a very, Dr. Raman, from a retina point of view, as you were saying, we have many participants. They were around 25 at one point, as I noticed. And it was a wonderful topic to be discussed. And not only for the retinal surgeons, but even for the anterior segment surgeons like me. And I would request Dr. Rajat to kindly thank everyone from Ambala Ophthalmological. Dr. Rajat. I think Rajat has disconnected. So again,
I'm here only.
hi Rajat,
Hello.
yeah, please.
Yeah, I am there. So Dr. Raman, Dr. Ruchi, and Dr. Mohit, we are highly obliged. We are yet to see such a good video, Dr. Raman. I never knew that retina surgery is such a beautiful thing. So you have a lovely videos and lovely art. Well, it was very good. And Dr. Ruchi and Dr. Mohit, we thank you all for this wonderful session. Thank you very much.
Thank you, sir.
Thank you, everyone.
Thank you,
Thank you, sir.
Thank you.
Yeah. Thank you, sir.
Thank you, Dr. Ramandi. Thank you so much.
Okay,
Thank you, sir.
Thank you very much.
Thank you. Okay, good night. Good night, sir. Good night,
Good night.
everyone.
Good night. Good night.
Okay.